Welcome everyone. I hope you're sitting there with a glass of wine in your hand or a beer or whiskey and something to snack on in the comfort of your living room. I'm still sitting in my office, but I do have a few comforts here to look after myself. Um, I'm going to start off by doing something which is actually a first for me. It's quite an unusual thing to do. I'd like to show you a case, and I'm going to show you my workstation so you can actually see what it looks like in reality when Peter and I look at these cases and what's involved. So this patient please try and remember this history. He's a 56-year-old gentleman, presented a week ago with hyperlipidemia, a mildly positive stress test, and he was sent in by a cardiologist for a coronary artery CT scan. As part of the coronary artery CT scan, in our centers, we do a calcium score as a routine, which is included within the CT coronary angiogram study. Now, this patient's calcium score was 9.14. I'm going to move the workstation screen into the main screen, which I presume that Sue, you'll indicate to me if there's any problem with it. What we have here is we have a number of images. We've got our 3D imaging of the heart. Now, the technicians actually give us this data. They've spent a lot of time working up every single one of the coronary vessels. And as you can imagine, the technology that one needs to do this is quite remarkable. And actually, it's extremely expensive CT technology. This is top of the range equipment. The scans in a single breath hold, it's ECG gated, and a lot of the time we spend is after the patient's left the rooms. I'm going to show you this LAD. I'm going to put a little line on it. This is the LAD coming down interventricular septum. When you touch it, the LAD comes up on these screens, and you can see here that I can actually rotate it 360 degrees. You might notice that up at the top here, in this area, I'll just switch off those lines. You can see this little calcific plaque. You can characterize it, and you can actually see that it's not causing luminal stenosis, and that is the reason why this patient has a calcium score of 9.14. The remainder of this vessel is pristine. I would then go through and look at every single one of the diagonals, the intermediate artery, and of course the circumflex and the branches. And as you can see here, each of those vessels is normal. I can actually go through those vessels with a cross-sectional technique. I can drag my cursor along, and you can see in the left bottom screen how it changes. You can see it in the cross section as I go along. Now, this patient happens, as you'll see in just a moment, when I hover over the right coronary artery, and here it is here on the screen over here that I'm rotating. You can see straight away that there's a little bit more calcium, which wasn't actually measured or included in the calcium score because it's not quite dense enough. But you'll see that from this point over here to this point over here, there's a complete occlusion with an enormous amount of soft plaque within the vessel. This is very severe disease in the right coronary artery, and it's an important finding in a patient like this who had only a very mildly positive stress echo. I'm not going to talk much more about this patient at the moment. If you want to come at the end with any questions, we can address issues like management possibilities. I'm going to close this down now. We're going to move on with our presentation, and we'll show you some more examples during the actual cases. But we're going to answer quite a lot of clinical questions which have been asked between Peter and myself. Some of them I will answer, some of them Peter will, some of them we will both discuss. So the first question, when should I do a calcium score or a CT coronary angiogram? Now, the tests offer very different information. The calcium score alone is a retrospective look at what damage and repairs occurred over time compared to other people in their sex, age, and gender ethnicity. So it has a value in a population-based study, but there are some limitations in value when you look at an individual, and particularly in a young individual. The CTCA has the ability to diagnose early vulnerable plaque and plaque characteristics, as well as the degree of stenosis. Most myocardial infarcts occur with a stenosis of less than 50%, with vulnerable thin-capped soft plaque, rather than the stable, dense, and healed calcific plaque that we see when we measure calcium scores. One of the biggest issues in answering this question when you do the calcium score versus the CTCA is, unfortunately, one has to consider the affordability and the costs of the test. The reason it's this division is that neither of them are covered by Medicare for GP referral. CTCA, however, does have specific indications where it is covered under Medicare, usually for symptoms or if there's some specific issues like looking for coronary anomaly. And it has to be referred by specialist. It doesn't have to be a cardiologist, it could be any specialist. Just give me one moment while I just move that to the side. Now, the other factor that determines whether you do the one test or the other is age factors. The calcium score has very limited value in younger patients because calcium, as I said, is healing plaque, and plaque very early on in younger people is soft plaque. It often takes some years to heal, and so we find that it's most useful over the age of 50 and very seldom of value under 45. You can run into trouble with giving people in their 30s or early 40s a normal calcium score when there's a lot of soft plaque, and you're actually giving them a golden handshake, which you shouldn't really do. Now, the next thing, if you cannot afford the test, then probably the calcium score is the better way to go because it is a very useful risk factor assessment, and the cost, just to give you an idea, is around about $200. On the other hand, the CTCA, which includes the calcium score, by the way, is somewhere in the region of $650 to $1,000. This is the gold standard in excluding coronary disease. Bear in mind when you see this cost, which is very high, I showed you a bit of that technology. It's extremely expensive technology. It takes the technologist about half an hour to do. It takes the radiologist or cardiologist co-reporting a significant amount of time to do it properly and to look at each of those coronaries. It's nothing like looking at a standard CT chest or or much of the other imaging that we do. Even some of our MRI scans are 5-10 minutes examinations. These take at least half an hour to review. This is just another example just to show you just a few differences. Up on the left top side, you can see how with the CT coronary angiogram, you see the contrast, but you also see the soft plaque in the wall of the vessel. Here you see the soft plaque outlined there. In this image right top, you see the calcium and you see that it's not causing stenosis. And in the bottom 4 images, you can see that there's a lot of calcium here, and you can see that it's narrowed. But when you look at the catheter angiogram, you see the narrowing, but you can't tell if it's soft plaque or calcific plaque. You get no information about the character of the plaque. The catheter angiogram is still the gold standard for measuring stenoses and for some of the smaller vessels, but it's got some pitfalls, and there are a number of areas where the actual CT scan has a lot of advantages. So, moving on, I want to get on to the next question. So, my patient would like a CTCA. Are there any reasons not to do it? So here we're talking about risk factors, and the major risk factor is that of contrast allergy. It's the same that applies as for all other CT scans that we do: chest, abdo, pelvis, arterial studies, the aorta, head and neck study. And for this reason, because of the contrast allergy, it's not widely advocated as a population-wide screening test. And unlike mammography, which is generally done non-contrast, although mind you, we have some newer applications where you can use it. So the big issue really is just the contrast issue, which I think all GPs, all doctors are aware of. And for most clinical indications, if someone needs a test, you do the test. You just explain it to the patient, make sure they consented properly. So I think that if patients understand the risk provided, you need to have informed consent for them, and they can choose to have the test if you explain to them that it is the best test available in excluding coronary disease. It is a better test in excluding disease than a catheter angiogram. And if you recall the previous slide, I showed you why. Because all you see in the angiogram is the lumen. You don't see the disease in the wall. So you can see a normal lumen, tell the patient they're perfectly normal, and they may not be. They may have significant disease. The negative predictive value, which means the reliability of calling a normal CT coronary angiogram study, is about 98%. Remember, no test in medicine is ever 100%. And this is a better negative predictor value than a catheter angiogram. Now, the other negative thing about doing the CTCA is radiation. And again, it's the same in any imaging test that you do except for MRI scanning. It does depend a lot on technology. Fortunately, I do have excellent technology in my site, but most of the I-MED sites that I'm aware of have very similar level technologies. The radiation dose for CTCA is about 0.4 millisieverts up to 4 millisieverts, which is equivalent to 1 chest x-ray up to 10 x-rays. So just think about that. That's equivalent to 1 chest x-ray. That's a full coronary artery CT scan. That's quite remarkable. One therefore has to consider this in the same way one does other radiation tests when ordering them on patients. We don't do them on very young patients. We avoid them in pregnancy. And when we do them, people need to know that they're getting radiation, but it's very low dose. The other issue which one needs to be aware of with contrast is renal failure. We have to be careful. We can't give it if the EGFR is less than 35. Next question. Presuming the patient has affordability issues, why would I still recommend a calcium score? Well, a general practitioner often has to decide whether statin therapy is appropriate in an asymptomatic patient who has borderline or intermediate risk of developing atherosclerotic disease. Studies have shown that the addition of the calcium score to a Framingham risk enables a much more powerful risk assessment. In fact, of all the risk factors, it is the single most powerful risk factor by far. The next most significant risk factor is family history. Primary prevention, as we all know, and screening is generally in the hands of general practitioners. So this is your game. This is, you are seeing the patients. This is your call. And we'll come to it in a moment as to why this is so critical for the general health of your patients and, in fact, the entire population. If you prevent cardiovascular disease, you will save more patients than all the cancers. Although there's no Medicare rebate, if all they can do is the calcium score, and if that is affordable for them, then it is well worth doing it when you do your risk assessment. I'm going to pass it over to Peter now, if you don't mind, Peter, just discussing the slide a little bit and then moving on to the next one.
Good evening, everybody. Firstly, I'd like to say it's been a pleasure working with the cardiac team at I-MED. It's a very advanced team and a good team, and we've done a lot of good work over the years. My role this evening is to provide a clinical perspective and hopefully a few take-home messages about what to do with the result you get when you send a patient in for screening or for a calcium score or for a CTCA. Not going to spend too much time on this slide. It's really self-evident how prevalent coronary artery and heart disease is. It's the leading cause of death still, only outdone by the COVID epidemic with that snapshot in 2021. But over the age of 60 in the Western world, males, 1 in 3 of us will have a cardiac event. And a similar number of females. And just to mention, in the Aboriginal and Torres Strait Islander group, 1 in 2 people under the age of 50 will suffer from a cardiac event. Going on to question number 4, how do I explain a calcium score to my patient? Very common question. I'm sure everybody who's dealt with cardiac patients has had this dilemma, and it's not easy. So I thought I would just debunk a few myths out there. And the first one I'd like to mention is, and it comes up over and over again, is physicians must clearly communicate that a 0 calcium score in a young patient does not mean we don't have disease. In fact, many studies show that young patients, the age 36 to 42, 90% will have a 0 calcium score, making it an almost normal result, but does not clear the person of having plaque. It merely shows that they have not had plaque for long enough for it to calcify. One could see this as an iceberg, where at the bottom of the iceberg is slow atherosclerosis, but we only see the calcification when we see the tip of the iceberg. However, a calcium score in an older patient is much more beneficial, and we'll get into that a little bit later. So all we can tell the patient that in broad-based studies, a low calcium score is a good thing. In young patients, we don't have much evidence to suggest they don't have plaque. In over 70-year-old age group, if your calcium score is still 0, that is a very satisfying result and very reassuring. And I think we can go to the next slide there, Ken. So in the general population, we grade calcium scores so that if a patient asks, so where do I fit on the spectrum, we've at least got some data to present to them. And here you can see no plaque, minimal plaque 1 to 10, 11 to 100 mild, 101 to 400 moderate, greater than 400 significant, but this one must stress is only calcified plaque. It tells us nothing about plaque burden, only healed calcified plaque. Can go to the next slide.
Okay, so is there a better way to calculate risk using calcium score? The answer is yes. By using an online calculator, you can get a much more accurate risk calculation. Now, there are two ways to do it. I'm going to go through it quite quickly. My preferred way personally is to use the MESA risk score, which is online, and we'll come to that in a moment. But one that is quite widely used by a lot of general practitioners is the Australian calculator. Here's the link to it here. Somebody did ask us a question about that, so that's why I thought I'll mention it. And this is what the Australian risk calculator looks like. And I've entered in a whole lot of data here, putting in age, cholesterol levels. It gives you a calculation point. The good thing about this particular calculator, the good thing about this calculator is it does take into account specifics for Australian risk factors in terms of First Nation people and some of the other details you can read for yourself. And it does take that into account, which the actual MESA calculator doesn't. But having said that, when you get to the calcium score, it only gives you an option to fill out if it's greater than 99. Now, that is really important, and it's very abnormal if it's greater than 99, but it does make an enormous difference if it's 150 or 350 or 3050. So that is something that this system doesn't accurately calculate, but that's not to say that it's not very useful, and certainly very helpful to use a calculator when you're determining risk factors and management. I'll just move on to the next one. This shows you the MESA calculator, which is online at this website. And the difference here is this is American data, so it doesn't deal with specifics, like, for example, it has here the African American and Hispanic nationalities. It's not as specific as for the Australian demographics. However, for the Caucasian population, and it does actually apply to a large extent with the other indigenous population. It has greater emphasis on the use of the calcium score, which you put in, and you just put in the other measurements. You get your measurements here. It gives you your estimated 10 risk of your coronary event is 12.7%. Now, the data that was put into the other calculator, which doesn't enable you to adjust for the calcium score, it just gives it greater than 100, that gave a risk of about 6 or 7%. So the risk is a lot higher when the calcium score goes up. And that's one of the reasons why I particularly like this calculator, and I think most cardiologists use this as well, although it is acceptable and still good practice to use the Australian calculator. So just to get back onto the next question, how does a CT acquire the calcium score? Okay, now the important thing is that it's non-contrast. The radiation dose is there, but there's no iodine, so that you don't have this risk of iodine, as we mentioned, one of the contraindications to the CTCA. It acquires a block of data. The software literally fills in the calcium with different colors. The tech then goes, puts a ring around it and adds it in and just puts into either the LAD or the circumflex or the left main, and he gets a listing eventually. Now in this case, you could have put it under LAD, left main or circumflex. It doesn't really matter. The detail's not important. What really matters is what the score is, and the score in this patient was very high. It was 768. There it is there. So that's how you do it. Now, the next question, Peter, I'm going to ask you this question. If a patient has a calcium score of 0, does that mean that they don't have disease and they don't need statins? So you mentioned, you've already answered this a little way, but the issue of treatment and statins, just to clarify that, please.
Yeah, so again, similar question. I think this largely depends, one, on age, and two, on your overall risk factor profile. And so again, the MESA score becomes important. But just something to take note of, a 0 calcium score on the coronary arteries, in big studies, when they look at the entire vascular tree, with patients with risk factors, even though they may have a 0 calcium score, they may have disease in the carotid arteries, in the peripheral vascular system. And it's been quoted that upwards of 50% of people may have plaque elsewhere. So I think we can't only rely on a calcium score to tell patients if they need statins or not, particularly in a young group. So even in a young patient, say a 40-year-old, who's got a very high chance, a 90% chance of a 0 calcium score, I would still punch in the data into the MESA risk score. And if his risk is the intermediate or certainly in the high range, I would strongly consider statins, particularly if his LDL cholesterol or lipoprotein B or lipoprotein little a is markedly elevated, and particularly if he's a diabetic or has a strong family history of premature coronary disease, because we don't want a patient to be exposed to a lot of very strong risk factors without any protection. So I don't think a 0 calcium score gives us enough ground. I just might add that a CT coronary angiogram with contrast, excluding any plaque, both soft and calcified, would make me a little bit more comfortable to choose lifestyle choices and treat other risk factors than to rush in with long-term statin therapy, because as we all know, atherosclerotic disease is an inflammatory condition with multiple risk factors and is not only the cholesterol that plays a role. And more data are coming out that people with diabetes and people with a strong family history are as much as at risk of damage to their arteries as are people with only a raised cholesterol. So the answer to that is you need more data. You cannot, on a calcium score alone, say you don't need anything, you're fine, because you're reassuring them prematurely. In an older patient, 70, 80, with a 0 calcium score, they've already been exposed to their risk factors, and I'd be much more comfortable not to give an elderly patient a statin for life.
Oh, thanks, Peter. Just to mention that it's important to understand the whole process of atherosclerotic disease, and we'll get to that in just a moment. But once one gets the lipids deposited in the wall, you get aggregation of platelets, and most of them heal. So that's what the calcium is. It's the actual healed plaque. Some of them may become unstable, they may trigger, they may rupture, and you may get thrombus, and that's when you get the sudden cardiac deaths. And the interesting thing about it, Peter, I think you agree, is that often you have no warning symptoms. I'll give you a chance in a moment again to talk about that. But just to emphasize that the calcium is healed plaque. It means that you've had plaque, it means you've had soft plaque in the past, and that it's stabilized. So I guess if you've got a calcium score of 0. We've already discussed what to do next, and I think we've covered that. So we're not going to go spend more time on that, but just to show you an example of a patient. This was actually a cardiologist, a young cardiologist, 35 years old, and his brother died of a myocardial infarct at the age of 32. So he booked himself in for coronary CT. We don't usually do the calcium score, but as it happens, it's 0, and it was no surprise. As I said, we get the calcium score at the same time anyway. But if you have a look at the coronary artery, the coronary angiogram here, what you see is this tight stenosis in the LAD, and that is a 70% stenosis, which indicates that it's hemodynamically significant. And this is the catheter angiogram afterwards, which correlates extremely closely, and that's before treatment and after treatment with the stent. So, coronary disease is quite scary stuff. And remember what I said earlier on, that family history is a very significant risk factor for these patients. Peter, I might just ask you just to explain a little bit about this slide in the atherosclerosis.
Yes, so I think most of us are familiar with the process of atherosclerosis, that it starts with damage to the arterial wall, in the past mainly by smoking, now the other risk factors we've mentioned. That damage results in an infiltration of bad lipids into the wall. Lots of other cells, macrophages, other inflammatory cells are associated with this disease and causes atherosclerosis, and the disease progresses from a fatty streak to a thin-capped, soft, vulnerable plaque, and finally, after many years, to a stable calcified plaque, and that is what the calcium score is picking up. But the disease is an ongoing process of damage, inflammation, and repair. And what causes cardiac symptoms is when that process causes intraluminal narrowing. And if it's a slow chronic process, you will only get angina on exertion when your stenosis reaches 70% or even 80%. What causes a sudden event is when a thin-capped, vulnerable soft plaque ruptures, platelets aggregate, and the artery is either subtotally occluded, known as a non-ST elevation infarct, or the artery can be totally occluded, as you see in the final picture on this slide, and that causes an ST elevation myocardial infarction. What we are hoping to do is treat the risk factors, treat the disease before it gets anywhere near this stage, or at least we know in which patient it exists. There are rare causes of symptoms as well, like spontaneous coronary artery dissection, much more common in females, and they have no atheroma. It's still under research why this occurs, but it's obviously a collagen problem. And then coronary spasm is a cause of symptoms where there's again no atheroma, but for some reason that particular patient is susceptible to coronary spasm, as is the case with patients with Raynaud's disease, as is the case with patients with other autoimmune syndromes. And I think we can go to the next slide there.
Okay, so I'll just put this question. My patient has elevated cholesterol, but is sensitive to statins and would prefer not to take them. How can I feel comfortable with stopping statins? The patient had a stress test and was given the all clear. So incorporated in this question, Peter, is the reliability of the stress test and whether you can stop the statins despite them having high cholesterol.
Yes, so interesting question, and one which needs to be better discussed with patients. Stress echo is a very good screening test for cardiac disease as a whole, because some patients present with aortic stenosis, present with LV dysfunction, present with a pericardial effusion, and that can be picked up very easily on the pre-testing echo pictures. However, it has very limited benefit in telling a physician who should be treated with a statin or not, because there is no way of visualizing the coronary arteries. If the patient has a positive stress echo, it's a very, very specific test for that. But that means that there is significant coronary artery disease and the patient is heading to the catheter lab for intervention. But as a risk tool, both SPECT nuclear testing or stress echo has no benefit in advising a patient, yes, to take a statin or not. And both stress testing and the nuclear MIBI study have very similar specificity and sensitivity. And that is why we've all heard the story of the patient who visits the cardiologist, has a stress test or stress echo, he gets told everything's fine, and he has a cardiac event 3 or 4 weeks later because we haven't visualized the coronary arteries.
So thank you, Peter. You might recall that first case that I showed everyone of a patient who had a very mildly positive stress test. The cardiologist wasn't confident, and yet there was severe extensive occlusion of that right coronary artery and very severe disease. So even though the stress test was slightly positive, it wasn't enough to really be helpful. It was the CT coronary angiogram which really gave all the answers. Moving on to the next question. How likely is it that calcium score will get a Medicare rebate? So I haven't heard anything yet. It is so-called pending. It is possible. This is a Medicare political economic decision. There's a lot of money involved in it from a government point of view to give that rebate. It's cost the country quite a bit of money, but I believe, and Peter and a lot of other people, that it would also save enormous lives, and it might actually save costs because you would diminish the number of interventions and surgery and all the rehabilitation and all those other costs involved. It's a very difficult thing to convince government that it would actually be a cost-saving measure, but I certainly believe it would be. In Australia, we've got one of the best health systems, but it does need updating and improvement. There are two prospects currently for Medicare rebate. The one is for calcium scores screening test, and it has been thrown around and discussed for people over the age of 50. And the other one is to enable GPs to refer for the CT coronary angiogram in symptomatic patients, considering the fact that GPs can refer for any other angiography elsewhere in the body, pulmonary angiograms. Why shouldn't they be able to refer for this? I was asked early last year to put some evidence together to support this, and I've done so. I haven't heard since. Unfortunately, the cardiologists are quite resistant to letting GPs take that. I think they don't want to lose control of the patients. Peter, I think you've touched on this, but this is the next question we've had. How accurate is myocardial perfusion versus stress echo versus CTCA?
So it's clear that as a rule out test, if any of these tests, stress echo or stress MIBI, are positive, their specificity for coronary artery disease is high. However, if the test is negative, we can miss disease, because in both MIBI and in stress testing, you firstly not visualizing the artery. Some small vessels will not present as ischemia on the stress test because there will be collateral supply from other areas. And on the MIBI study, you're comparing a rest test to a stress test. And if there's significant ischemia at rest, when you stress the patient, there won't be much change. So the physician will call it a negative test. However, in good centers, CTCA is extremely reliable as a rule-out test. And you can see there the quoting, as Ken said earlier, is upwards of 98%, which is a significantly good result for a rule-out test.
Right, I'm going to give you another case study also to illustrate that point. This is a 40-year-old, again, a young male who has chest pain. So he was symptomatic. He went into emergency at St. Vincent's on a Friday, and he was sent home. He had a negative stress test performed. He was given the all clear. He continued to have symptoms over the weekend. The GP called me up on Monday morning because he went into his GP. I said, let's do a coronary CT. This is what his coronary CT looked like. On the left-hand screen, you can see the lumen of the vessel. You can see he's got a little bit of disease in the wall, but right over here, he's got a tiny pinpoint narrowing. You can hardly see the lumen of the vessel. What you can see is that this is a 98% stenosis and that it's caused by soft plaque. There is no calcium plaque to be seen anywhere in the region. And once again, you had someone with a calcium score of 0. You have someone here who had symptoms, and then he had a negative stress test. And this guy was on the edge of having a major coronary event. Fortunately, the GP did the right thing. He had his CT coronary angiogram study, and there's the stenosis on the angiogram. So my question back to GPs as a whole is the $600 to $800, $900 for the CT coronary angiogram worth it or not? Well, I guess in this guy's situation, it certainly was. Question number 13. Peter, I'm going to put this one to you again because a question from the GP was, I have a patient with a calcium score well over 1,000 from 20 years ago. So he had it done 20 years ago. He's still well and fit. How should he manage him going forward?
Good question. With it being 20 years ago, I'm sure this patient is already well into his 60s, 70s, unless he had a very high calcium score in his 40s. So this patient is in a stable situation. He needs aggressive risk factor management. If he's asymptomatic, exercising well, and he's had this for 20 years, I would say medical management is going to be paramount here. Blood pressure control, cholesterol to target, watch out for weight gain, manage his sugars. And if you are concerned, this is where a functional stress echo or MIBI study is very valuable. But on this clinical scenario, I think he would easily cope with a functional test, and he is for medical management, and he can be reassured. And that's another important point. A calcium score of 1,000, as you can see by this case, doesn't mean you're a time bomb. You can live with a calcium score of 1,000, stable, with good blood flow, and no symptoms for many, many years. So an interesting case and very common.
Thank you, Peter. And here's an example of a case study. This patient has a calcium score nearly 2,000, but if you look at the vessels, there's a little bit of narrowing, but there's really no significant high-grade stenosis there at all, despite an enormous calcium score. And we actually, with the later technology, we often get patients with really high calcium scores, and we get excellent quality imaging out of our systems. So, we still do the study. On the next question, the best non-invasive test to assess the imminent danger of an MI in a patient with angina. Peter, we have to kind of hurry it along a little bit. So a patient with angina, best non-invasive test.
I think, the only test that you would refer for if you're concerned about someone who's having angina, I mean, if he's got symptomatic angina at rest, you would want to refer him to casualty for urgent management. If it's intermittent and you've got a bit of time on your hands, then a CTCA with contrast, not only a calcium score, would be the test of choice. I wouldn't be referring for stress testing in this situation.
Okay, this was an interesting question. How have the COVID vaccines, particularly mRNA, affected the health of the nation? I think, Peter, you'll have to take this one.
Yeah, just briefly, I mean, as a clinical cardiologist, I've seen an increase in patient referrals because of both COVID and the vaccine. Where the vaccine's concerned, I have not seen pathology, for example, severe pericarditis, myocarditis from the vaccine on its own, and that's anecdotal because it's my practice, although I know studies do say that this occurs 1 in 2 in every 100,000 vaccines, which is a low number. But definitely the live COVID virus has caused significant myocarditis and pericarditis, which we have personally treated and seen.
Thanks, Peter. A patient chooses a CT coronary angiogram, his calcium score is 0. The CTCA, however, finds soft plaque, but no stenosis. So soft plaque present, no stenosis, calcium score 0. How does this change management? And is this questioning the value of the calcium score? I guess some of this we've covered, but just your thoughts, please.
I think this patient's age determines everything. If he's a young patient, 40, less than 50, we definitely want to address all his risk factors, depending on his cholesterol level, smoking history. This shows he's already started the process of atherosclerosis, and I would have a low threshold to start him on some treatment, particularly if it was plaque in the proximal LAD, proximal big right coronary. Less so if it was a small vessel. And each case needs to be taken on merit. If this was a 90-year-old or an 80-year-old patient, firstly, it would be rare to find soft plaque, and I wouldn't be that aggressive in that patient's management. So that question is age related, as can be seen in this next slide.
So this question's similar. A patient wants to come off the statins. Is the calcium score good enough? So you've basically said it's age related. Young patients less than 45 to 50, vulnerable soft plaque may be missed. So be careful, the young patients. You've obviously got to consider the other risk factors and the calculators, and then in low risk groups, repeat the scan or the calcium score in 3 to 5 years. Is that fair enough?
That's fair enough.
So here's another question. My patient had a stent 5 years ago. He's concerned that it needs to be checked. What test can we do? Is a stress test good enough? I'll just show you what the CT coronary angiogram of a stent looks like. This is a stent on the left hand. You can see very well through the stent. You can see that it's patent. He has another very patent normal stent in this area of the vessel, and he has a normal long stent in this vessel, which looks like that. This is the LAD, and another stent more distally. So these stents are all fine, but he also has new disease, and you can see that it's soft plaque and it's high grade. So in fact, the coronary CT has not only shown us where the stents are and that they're in good order, but that there's other new lesions which are a concern. Peter, how does stress testing work with stents? Can you just mention something about that?
I think it's more about symptoms, what is their exercise tolerance, etc. And it's similar. I don't think it makes a difference for a stent versus no stent. The stress test is good prognostically for 1 to 2 years if it's performed adequately with no ischemia. But the sensitivity still for other lesions, as you've depicted very nicely here, the sensitivity for picking up new disease is not as high as the CTCA. But having said that, good medical therapy, which all patients with stents should be on, aspirin, statin, blood pressure treatment, and a good stress echo, in my practice, is adequate.
Okay, so next question. My patient's had a triple bypass, has some symptoms. how can I check the grafts? So I've shown you some images here of the grafts on a 3D image. You can see the graft. This is a catheter angiogram. Here's a graft which has got 2 patent stents in it, and here's the stent coming in at the anastomosis. This is the left main, which has a patent stent. So just to answer the question, coronary bypass grafts are not actually coronary arteries. They're not moving with the heart to the same extent. They're not as challenging to get good imaging as coronary arteries. And in fact, we get exquisite visualization of bypass grafts. We get very accurate assessment of when they've atretic and starting to go down, when they're occluded or partially filled. And the other important thing about this is that at a catheter angiogram, which is the traditional way that they would check the graft, it's often extremely difficult to find the origins of these grafts within the aorta, and it becomes very complex when there are jump grafts, and there are some of these grafts can be very complex. So it can take a catheter angiogram a long time to do it properly, and very challenging. Although it is still a good test. Remember that the catheter angiogram is very invasive. Relatively, there's catheters going into the groin. You can bleed. You can get hematomas. You're feeding wires up into the vessels. You can knock off little bits of plaque. There's a risk of knocking something off and going to the head, catheter angiograms are not without certain mortality and morbidity. So to look at a cabbage, look at a coronary artery bypass graft as coronary artery CT is a superb way to do so, and I think it should be done much more frequently. But obviously, if the patient is developing symptoms, then you would do it. If they're not developing symptoms, probably not necessary to do it. I think this is one more question, Peter, and I'm going to pass this on to you. We are getting to the end. We want to leave time for more questions. Asymptomatic patient, calcium score more than 100. Should the GP refer to a cardiologist for consideration of CTCA or anything else? Or would starting statin therapy be enough by the GP? Can you just give your thoughts on it? Should they refer it on to yourself or one of the cardiologists?
I think it's worth a one-off referral to a cardiologist. My practice, and there's many studies to bear it out, that in younger patients, a calcium score of greater than 100, you would be starting a statin after discussing with the patient exactly why. I would do a functional test on a patient like this, and then each patient is different. What we've discussed the whole night is a calcium score of 100 could mean a lot of disease. And I just wanted to raise one point, if I may. Just give me 2 minutes. This is a very important point. If we turn it the other way around and we say, for all the patients who have got coronary artery disease with greater than a 50% stenosis, no symptoms across the board, what percentage have a 0 calcium score? 14%. If we break it up into ages of greater than 70, 5% still have a 0 calcium score. Less than 40, and this is the take-home message, less than 40, 58% of people will still have a 0 calcium score. So I think that's just another way of, hopefully I haven't confused anyone, but this patient should be on a statin in my practice.
Thank you, Peter. I think we've come to the end. Thank you very much for your attention. Thank you to my colleague for providing excellent clinical insight into the condition. Peter reports a lot of coronary CT together with myself in the center. He's been doing so for many years, so he is an expert in the area. And I think it's very powerful to be able to work with as a radiologist together with a cardiologist in this interesting field, which is probably one of the most important in medicine, considering that cardiac disease kills more people than the total of all cancers added up and put together. And if you think of what's involved and what we put into breast screening, breast imaging, prostate, urological conditions and everything else, and cardiac disease is the biggest one, more than the total of all of those and all the cancers. And the great thing about it is that there's major advances in prevention. There's a lot of stuff one can do to prevent people from dying and having severe morbidity. There's a lot of fantastic treatments, interventional treatments, and medical therapy, and is very powerful. I might also mention it's an extremely useful tool for compliance. There's nothing stronger in terms of compliance than showing a patient your calcium score is XYZ, or your coronary CT shows XYZ with a lot of soft plaque. You need to lose weight. You need to take your medication properly, make sure you're eating properly and controlling your diabetes, and you need to make sure you see your doctor regularly and for regular checkups, and of course exercise. So I think it's a very powerful tool in terms of compliance, and you can't underestimate that. So thank you very much. I think we've got a few more questions coming in. We would have time to take some.
Thanks, Ken. We did have quite a number of questions come through. I've tried to group them as best I can. So the first question is, when referring for a calcium score, what information is required on the referral?
It is useful to have as much information as possible. If you actually give us the details like the family history, the systolic blood pressure, the cholesterol levels, we can actually put that data into the MESA calculator and actually give you, in addition to the calcium score, the 10-year risk calculation. We can actually give you that information. If you don't give us that information, then you need to take the calcium score, do it yourself within the calculator, and then you'll be able to interpret the calcium score with your patient in a more appropriate manner than just giving them a number. You'd be able to actually work out the risk. So yes, clinical information is important. Remember though that it's not a Medicare requirement, because this is not a Medicare rebatable item, so you don't have to give a history. It's not essential. It's nice for us to have always as much history as we can get as clinicians and radiologists in particular. Sometimes we don't get enough. It's always appreciated, but it's not you're basically just asking for a score. It's like sending the patient off to the pathologist to get a blood test or your cholesterol levels. You send them to us, we give you the score, we send it back to you with the score. That's what it is. It's just like a blood test, and it's not a bad idea to think of a calcium score a bit like that. It's not actually, it happens by chance to be a CT machine that's giving us that score rather than a pathology laboratory. We're not actually sitting there and doing analyses of the vessels and looking at the calcium in detail. We're just adding it all up and it's giving us a number. There are a few cardiologists who want to know if it's proximal or distal, if it's in the LAD or the diagonal, but that in itself is controversial, because it's very interesting that it has been shown in the literature that when you do have a lot of calcium in the vessels, the next plaque and the one that causes the stenosis, the coronary event, is not in the area of the calcium. It's in another area of the vessel which is non-calcified. So the actual location of the calcium is actually irrelevant. You can have a very high score in the left anterior descending artery of 800, 900, and you can have no calcium in the right coronary, and the patient has a coronary event that's in the right coronary artery. There's no association to it being in that left coronary. So yes, more information, please. Next question, thanks.
Yep, so I've kind of grouped these two questions. So will the calcium score be affected if the patient is on calcium channel blockers? And then is there any medication that increases our calcium score? So if we can just group those, that might be a question for Peter maybe.
Yeah, thanks for that question. So calcium channel blockers, work on the vessel wall in a completely different area to calcium. So the answer to that is there's a negative effect. Interestingly, the second part of the question is quite topical at the moment, in that statin therapy has been shown to actually increase the calcium score, but decrease cardiac events. And so the thought is that taking a statin causes the plaque to calcify a little bit quicker and a little bit better, and stabilize the plaque, and therefore lead to less events. But definitely statins have been shown to increase the calcium score compared to placebo.
Thank you. It's 8 o'clock, so we will wrap up for the evening. As I said, we had a lot of questions this evening. We will collate those questions. We might get yourself, Peter, and Ken to go through those and answer them. We'll put those up on our website, so keep an eye out for those. Thank you, everyone, for joining. Please take the time to fill out your evaluation form, which can be found in the handout section. And again, thank you to our speakers, and thanks everyone for joining us this evening. Have a good night.